Dear audience, today is my great honor to introduce one of our recent studies to all of you, and it's a comparative cohort study about calciphylaxis, which is recently published in Mayo Clinical Proceedings, and we found it truly meaningful. And we hope that this study will irritate the sparkles in your mind. And the title of this study is Patient Reported and Clinical Outcomes Among Patients with Calciphylaxis. Next, I'll show you what's in this study. First, I will briefly introduce what is calciphylaxis. Actually, is commonly seen in patients with end-stage renal disease as a complication of CKD and BD. It mainly involves it's like small artery calcification, meaning involves subdermal area, and it could result in occlusion of arteries in skin area, and also it will result in ulcers or even necrosis of the skin. It's a rare disease with high mortality rate. The mortality rate within 1 year could be as high as 30 to 70%. And it could also be resulted from other factors like tumor, vitamin K deficiency, or the steroid use, and many other factors. Unfortunately, there was no approved treatment for this disease. Some specific therapies included hyperbaric oxygen therapy, sodium disulfide treatment, and also we have a new drug named SNFs 472, which was still in clinical trial. An important feature and outstanding feature of calciphylaxis is that patients with calciphylaxis may have unbearable and refractory pain, which is always disproportional to tissue damage, and it could be refractory to many strong painkillers like opiates, and is a common reason for patients to withdraw from medical care. The mechanism is not very clear. It may due to the ischemia and nerve inflammation of this disease. There was little evidence about the meaning of pain in calciphylaxis. There was one study exploring the association between clinical presentations and the histological features of calciphylaxis. We can see that the fibrin thrombus might be associated with pain severity in patients with calciphylaxis. And there was one case report with two calciphylaxis cases in it. So author concluded that the pain could be anticipated within 2 weeks, and the wound healing may take months for these patients. But the evidence was too little that we actually do not know whether the pain improvement could be seen within 2 weeks, and was the meaning of calciphylaxis pain improvement for their diagnosis or prognosis of these patients. So here we hypothesize that the pain score improvement can be seen during the first 14 days of hospitalization among a special group of patients, which is hospitalization patients. And the patients with pain improvement in the first 14 days of hospitalization may have a favorable outcome in terms of lesion improvement, amputation, and survival. So according to our eligibility criteria, we screened 345 patients in two large database, which are RPDR and PCB database. And finally, we found that 111 patients met our eligibility criteria, and they were finally included in our study. For data collection, we collected the demographical information, complicated disease, risk factors, wound features, treatments and outcomes in these patients. And we also collected the highest pain scores on each day during the first 14 days of hospitalization. The pain improvement was defined as any decrease in pain score on day 14 compared with day 1. For data analysis, we first present the graph over distribution of the pain scores, and also we analyze the change of pain scores. And we compared the clinical characteristics between patients with and without pain improvement. We also tried to explore the association between pain improvement and outcomes interested, and some treatments and pain improvement by using logistic models and Cox models. And we also did some sensitivity analysis on some subgroups interested. Here comes the results. Here we can see the distribution of pain scores on day 1 and day 14. We can see that on day 1, more than 50% of the patients had a pain score of 9 or 10. But on day 14, the majority of patients had a pain score from 6 to 8. Here we present the pain score difference between day 14 and day 1. As we can see here, most of the patients had a pain reduction from 4 to 1, or a pain increase from 1 to 2. Although the pain score on day 14 was lower than that on day 1, but there was no significant difference between the two groups, between the 2 days. And here we can see the pain score variation in 2 weeks of hospitalization. As we can see here, the pain score, the mean of the pain score was decreasing slowly during the 14 days, while the median was fluctuating up and down. Here we found in all the patients, there were 49 patients that had pain improvement. And the patients with pain improvement had a higher pain score at day 1, and was less likely to have diabetes history, malignancy history, and extremity involvement. Also, we found that patients with pain improvement was associated with surgical debridement and opiate use at baseline. For the outcomes within 6 months after the 14 days of hospitalization, we found that patients with pain improvement was less likely to go through an amputation within 6 months. But we didn't find any association between pain improvement and lesion improvement, or pain improvement and mortality within 6 months. We compared the mortality rate in different time period between the two groups, but we didn't find any difference. For overall mortality, there was no difference as well. We also explored the relationships between pain improvement and some treatments. what we discovered is that the surgical debridement during the 14 days of hospitalization might be was associated with the pain improvement in 3 of the 4 models fitted here. We did subgroup analysis in dialysis patients. In the 111 patients, there were 88 dialysis patients, and 67 of them were on HD, 21 of them were on PD. Here we didn't find any association between pain improvement and then outcomes within 6 months, and also the overall mortality rate. For the treatments, we still found a strong association between surgical debridement and pain improvement. We also noted that HBO therapy before the end of the 14 days of hospitalization in this group of patients might be associated with pain improvement. Another sensitivity analysis here included setting a different pain improvement criteria, which is more strict, is at least 30% of decrease in their pain score. And also we did sensitivity analysis by omitting patients with a baseline pain score of 0 or omitting patients died within 6 months. But since was replicable only in the second sensitivity analysis models. In conclusion, we found that the pain control remains a challenge even among hospitalized patients with calciphylaxis. And pain improvement may indicate lower risk of amputation. And we also found potential improvement in pain in patients with surgical debridement or HBO therapy. This is the first and largest study to comprehensively explore the clinical significance of patient-reported pain in calciphylaxis patients. But it still has some limitations. First, it's only focused on hospitalized patients, so it might not be generalizable to another population. And it's a retrospective study. There could be some confounders which was not recorded and hard to be controlled. In the future, we propose a prospective study focusing on pain score improvement in both outpatient and inpatient calciphylaxis patients. And we found that the strategies to address the pain and overdose of opiates in calciphylaxis is in urgent need. Thank you for listening. And if you are interested, you are interested in this topic, please feel free to contact me through the email below. Thank you so much.